Hi, everyone. Welcome to another episode of our Sarcoma Sisters podcast. And we're so excited today to have Dr. Andrea Hayes-Jordan. She is the chief of the Division of Pediatric Surgery and surgeon-in-chief at the North Carolina Children's Hospital at UNC. And I don't know, there's so many exciting things about Dr. Hayes-Jordan. I'm just going to fangirl on you for a minute. So I was a fellow at MD Anderson Cancer Center when Dr. Hayes-Jordan was the head of pediatric surgery at that point. And I was always, it was always so great to talk with you because you would talk to me like so many surgeons, have the reputation of being really good surgeons, but then not really good at talking with humans.
Yes.
Like I was friends with a lot of the PAs and MPs, and they would always talk about you and how amazing you are, not only as a surgeon, but as a human, because you would actually talk to everybody and connect. And that, I think that makes such a huge difference. And so it's so exciting to have you on here today. And then, when I was doing my research on you on the Googles, I also noted that I did not know, which is another great honor to have you on this, that you were the first African-American female pediatric surgeon board certified in the U.S.
Yes.
Woo!
Yeah.
Wow.
Yes.
Wow. I mean, I'm just like, my heart's beating so fast because it's just so cool.
Well,
So thank you so much, because we don't just have like a pediatric surgeon who's an oncology surgeon on the show. We have like the leader in the field. So thank you so much for coming on our show today.
No problem. My pleasure.
All right. So to kick us off, we kind of had, just as you know, this is focus for families with sarcoma and for patients. So we have a bunch of surgery questions, but I just had a question too, kind of as a mom myself, because I think my son's 2.5, and when I first became a mom, I always thought like it didn't matter if you were a parent or not when you were treating children with cancer. But then it's like, once I became a parent, I thought, it really did add a whole another level of empathy. And I was just wondering if you could just kick us off by saying, as a parent of 2 children, did it change the way you talk to parents and your career, kind of like how, and has that been part of what makes you so empathetic and such a great communicator?
Yeah, I think you're right. Having children really adds another level of comprehension. Not that you can truly comprehend what the parents of a child with
Right.
cancer are going through, but just to be able to understand how their thought process is and what their questions mean, try sort of the meaning behind the question. It also helps in my patients. I'm when I have a new patient, I have an hour and a half blocked out to talk to them. And so I'm not in a hurry to get through it. I want to make sure that I answer all their questions because I know how important that peace of mind is. And as a parent, you also know that you're part of a community. And so as soon as you get home from the doctor, your mom or dad or aunt or uncle is going to say, well, what happened? What did they say? And then you
Yes.
remember. So I appreciate when parents want to write things down or record the conversation. It doesn't bother me. I totally understand that that's an important component of taking care of your child and being a good steward of their health care. I think without the kids, that you would still do it, but it wouldn't be um, as personally relevant. And so I have a lot of empathy for parents who go through that. And then when you're talking about surgery, you're asking someone to consent to hand their child to you, to really handing you their child's life to take out a tumor. That's an important bond. I think of it as a bond that needs to be created between you and the parents, because it's about the trust. It's about making sure they know that I know how important it is to be meticulous and accurate, and how important, of course, their child's life is, and balancing taking this tumor out versus making sure that we're going to restore them to excellent quality of life. So I think that being a parent definitely helps you appreciate that.
Yeah, thank you. Wendy, you look like you were going to say.
I was going to say something, and then
Yeah.
I heard a ding, and I was trying to figure out if it was me. No, I think that's so important. I think when I think about surgery for my patients, and I think about when my own children have had to have surgery, that conversation, I feel like before I had kids, I underappreciated it, how the weight of that conversation, even, you know, for my children, it was minor surgeries, but these surgeries that we're talking about, Dr. Hayes-Jordan, these are big surgeries. And so what is your, when you go in, like as an oncologist, if I have a patient with a sarcoma, I say, you need local control to have this tumor removed, and I refer them to you. Can you kind of start to lay out what you do before the patient hits the room with you, and how you kind of walk through the decision making of what you weigh in terms of recommending things or not recommending things? Because I think there's a little bit of mystery that comes back. My patients tell me, well, they recommended this, but then I went to my Facebook moms group and other people are having this surgery, and why is that different? And so I think there's a little bit of mystique that I hope that this conversation can clarify, of what do you do before they come, and how do you weigh the pros and cons of each surgery for each individual patient, as general as you can get it, because I know it's all very specific to that one patient.
Yeah, that's a great question. And when I'm referred a patient from a colleague like the two of you, usually you all give me a great history on, you know, what happened. But I go back through the chart. I look at the chemotherapy that they've received. Usually when they come to me, they've already received chemotherapy. Sometimes it's at the time of diagnosis. And I make sure that the pathology is accurate, because our surgical approach, as your chemotherapy approach, really completely depends on the histology and the pathology. So that's the first thing I do. Look through all the other records, and then I look through the imaging. Obviously, as surgeons, I'm taking out something that we have an MRI or a CT image of. And I look at that very carefully to determine the risk to the patient of me taking out that lesion. So, for example, if it's a tumor, a sarcoma tumor in the, let's say, the arm, and what I want to look at is it close to the nerve? Am I going to have to take out the main nerve to the arm? Am I going to have to take out the main artery to the arm? And so I will be able to tell the patients in my conversation what the risk is. So the word resectable, which is a word that gets thrown around when you're talking about surgery, is really a relative term. So, for example, if you have a tumor of the extremity, if you do an amputation, that's technically removing the tumor, but it's not the most optimal thing for the child. So when I'm looking at the imaging, I'm trying to see, can I get a negative margin, so to speak? That's the word they use a lot in sarcomas. Can I get a negative margin? And that means that when I take out this lump of tumor, ideally, I want a rim of about a half an inch of normal tissue all the way around, circumferentially around the sphere, if you want to think of it as a sphere. And if I'm looking at the imaging and right next to the tumor is the main artery and vein to the arm, then I'm going to say that that's not resectable, meaning I can resect it, but I have to do an amputation. And that, when we as sarcoma surgeons say resectable, we mean without loss of form and function. So can it be removed safely without loss of form and function, and be oncologically good for the patient as far as taking out all the cells? So if there's a lump in the arm and you want to take out about a half an inch rim of normal tissue all around it, and I look at the imaging and I see that that's possible, that the tumor is that far from a critical structure, then I'll come back to the parents and say, this tumor is removable, and then we'll talk about the risks of actually doing the surgery. I try to put it in context of the tumor, because some sarcomas are sensitive to chemotherapy and some sarcomas aren't. So as a surgeon, the second thing I have to identify is this a chemosensitive tumor? So first look at the pathology, then look at the imaging. So I guess the third thing is this chemosensitive? If it's a chemosensitive tumor, I will talk to one of you guys and say, have we used as much chemo as we can in this patient, either in following a protocol or off protocol? And have we reached what I call a plateau in the response to the chemotherapy? So for the parents, a tumor start off sort of this big, and then it gets smaller and smaller, and then over 2 or MRIs back to back or CT scans, if it stays about the same size, that means that the chemo is not going to do very much more if we give more chemotherapy. And so that's the time to do the surgery. And making the tumor smaller makes the risks of the surgery smaller and makes the chances that I'm going to get normal tissue all the way around, that is negative margins, much better. So if the child can tolerate the maximum amount of chemotherapy, that's the best thing. And that allows me as a surgeon to be able to achieve a negative margin and not leave any microscopic tumor cells behind. Um, for a pediatric surgical oncologist, that's critical for us to make sure we don't leave any tumor cells behind that we can't see, and that's what we mean by microscopic. So if we don't leave any tumor cells behind, that's the best we can do. And then you all with the chemotherapy will continue to treat the child so that there won't be any tumor cells that escape from the tumor bed where I've removed the tumor.
And those
Does that make sense? Is that sort of?
Yeah, no, that's great.
Okay.
You explain it amazingly.
Yeah, exactly. I always love sitting in on the consults with my surgeons.
Yes.
I learn so much every time.
Yeah.
Those microscopic cells or margins that you left behind, that you talked about not wanting to leave behind, also can be called positive margins, which is a little bit of a misnomer if you think about it. Like it,
Right.
to us, it means there's tumor left behind, but to somebody else, positive sounds good.
Good. Right.
Those are things we don't want. And I think, and correct me if I'm wrong, I think inevitably through the course of a surgeon's career, every once in a while, those positive margins or those microscopic cells are left behind for various reasons. Can you explain how that could be? Like, we think we're going to be able to do it, but you get in there and you see things that we can't see on MRI. So can you kind of walk through what that looks like sometimes?
Right, exactly. I think, MRIs and CT scans and PET scans are great. They're very accurate to the point that they can be, but they don't tell the whole story. And oftentimes we get in there and maybe the tumor has grown since the imaging. Maybe the imaging was a couple of weeks ago or a month ago and it's gotten a bit larger. Or it's possible that the characteristics of the tumor, meaning whether the tumor holds more or less water, makes it harder to see how it infiltrates the tissue when you're doing an MRI. So you can get in there and be surprised. So let's say I'm looking at the imaging and I say, oh yeah, there's about 1 inch between the tumor and this main vein. Well, it could be that it looked like it was that far away, but it actually is, the vein is this long. So in one part, it's 1 inch away, and in another part, it's right on top of it. And so then you're faced with, oh dear, now I can't take out this vein. So you accept the fact that, in lieu of doing an amputation, you would accept a positive margin there. And as long as I don't leave any visible tumor behind. So I'll look at the vein and use the scissors or the scalpel to cut the tumor off of the vein, leaving the vein intact, or the artery or the nerve or whatever it may be. And you might have to take off a small piece of it, but your goal is to remove everything you can see with your eyes. Now, in a very rare situation, you might get in there and realize, you know what? And usually this is in the abdomen because the extremities are a little more straightforward. And you get in there and you go, you know what? I can't get a negative margin. This is going behind the colon into the blood vessels. I don't want to have to do an aggressive removal of 100% of the colon. And you may, in a chemosensitive tumor, say, let's just back out and not do the surgery, or let's add radiation now because that will be safer for the child. So you can get in there and see things that are different from the imaging, and it's nobody's fault. It's just the characteristics of the tumor. But first, we want completely negative margins. But secondly, if we can't get completely negative margins, we will settle for microscopically positive margins, meaning leaving microscopic cells behind on a critical structure that you don't want to remove because you want to maintain the child's quality of life. So the reason we would have positive margins is that we know we're cutting right on a critical structure, but we don't want to sacrifice that. And usually I'll call the oncologist after surgery and say, hey, listen, I know I left some microscopic tumor on this, but I thought the better part of valor was to do that and maybe do radiation afterwards. Usually in sarcomas, it's radiation that helps us preserve the limb or preserve the colon or whatever we're trying to preserve. But I think it's important for the parents to understand that there was no mistake made, so to speak, that it was just how the tumor was, and trying to balance removing all the tumor and restoring the child to a relatively normal quality of life.
Thank you. That's very helpful. And you mentioned radiation in the scenario where you get in and say, "Ooh, this is like I can't even do the best surgery that I can do is not good enough," and you kind of completely back out or kind of abort the surgery. And let's say the oncologist gives a little more chemotherapy and decides to do radiation. Can you talk about how radiation may or may not change your surgery if we do radiation before a surgery? And kind of how that plays out, what radiation does to surgery, basically.
Sure, sure. Yeah, radiation is it's really helpful a lot of times in a lot of different sarcomas, but not so helpful in other sarcomas, and that's just based on the location of the sarcoma and the surrounding tissue. So, for example, in the extremity, we like doing radiation ahead of time because what the radiation does is it causes a swelling around the tumor. So deciding to do radiation before surgery means that I've looked at the imaging and said, I can't get this out without an amputation. Let's try radiation and chemo to get it smaller. And then if we can, then maybe we can avoid an amputation. So when you do the radiation first, what happens is that inflammation sets in, just like you would for any other wound, if you think of it as a wound. And so just like if you banged your hand, it would swell up. When you do radiation, there's swelling circumferentially around this sphere, and the swelling pushes the critical structure away just enough for me to get my knife in there. So whereas I looked at the imaging beforehand and I saw that it was, let's say, right next to the main nerve in the arm or leg, now you've done radiation and it's shrunk away from that nerve. And not only that, but it's created this area of softer tissue that's just swollen tissue with water in it, essentially. And it makes it very straightforward for me to cut that away from the nerve. Whereas if it, without the radiation, the tumor cells in the tumor would be growing into that nerve, and it would make it technically difficult, not impossible, but technically difficult to cut that away from the nerve and get a negative margin. So the radiation actually helps us in the extremity, and we have to time it so that it's not too late after the radiation, so it hasn't set in as a scar. Again, thinking of it as a wound. So early after you hit your hand, it gets swollen, and then if you get a scrape, then you get a scar. And the hardness of the scar makes it more difficult to do the surgery. So there's this window of time, a month or so after the radiation, where it's ideal to do the surgery in the extremity so that you can take advantage of the swelling, but the scarring hasn't set in, so that the tissue is not so dense that you can't separate it from the normal critical structures. Now, that's in the extremity, but that's different in the head and neck and in the spine and in places where surgeons are dealing with not just critical structures, but life-threatening structures like the spinal cord. So in that situation, the radiation is helpful by itself, but then we wouldn't want to go in surgically afterwards into that area. That would just be the primary treatment. If it was in the head and neck, around the spine or around the throat or the airway, the going back in that area would just be too risky as far as damaging the normal structures around it. And the same thing with the pelvis. If you have a sarcoma tumor around the bladder or the prostate gland and they do the radiation, it can be more difficult to go back in there because the intestines then become stuck to the tumor that had the radiation, and you can't separate it, and it makes a lot of problems with the bowel. The bowel doesn't do well with radiation. Muscle is good, bone good. The bowel, radiation It's not friendly to the bowel and can cause all kind of problems with the intestine and digestion, etc. So we don't like to do bowel surgery after radiation because it basically causes a lot of problems for the patient as far as eating down the road.
Yeah, I think that's so important that, you know, kind of just in that list of the things you were talking about, it just shows the nuances of each tumor type, each location type. Sometimes age is a factor in whether we do surgery or radiation. And so I'm glad you mentioned like the head and neck. I know we have a fair amount of rhabdomyosarcoma listeners, and there's a lot of head and neck rhabdomyosarcoma where we primarily do radiation and not surgery. So we've learned through, you know, trials that that's not particularly helpful. So, and I also have to say, as a fangirl, it's been 10 years and nobody's ever actually explained that pre-op radiation.
The same thing.
And I'm like,
I know.
oh, thank you.
I know. I never had heard that either. That because I just assumed that it was never easier to operate after radiation, and I never even knew that when it was on the muscle that it might actually help out. Like I never heard that. So
yeah, it
thank
helps
you.
out. Yeah, it does.
Yeah.
It does.
Oh, we're learning so much in our podcast.
Good. Yay.
We really started this podcast for us, but
I know it will truly. Oh, that's so awesome, Lisa. I've been asking all the questions. I'll let you go.
Well, I did want to mention one of the other areas that you're truly unique and a pioneer in is the desmoplastic round small cell tumors.
Yeah,
Oh my gosh,
yeah,
DSRCT. That's why we just say DSRCT. But not only in your surgery, which I do want to talk about that, but also the fact that you do bench research, because actually I don't know any other surgeons, I'm sure they exist, who do bench research, but none that I know of. So I wonder if you could talk about, actually wherever you want to start, if you want to talk about what the research is that you do in the lab or the surgery itself, but if you could hit on both, because this is a super rare tumor, like all sarcomas are though, you know, all the tumors we talk about are really rare, but it's one place that you've really pioneered advances in. So I think it's really important, since we have you here to have you talk about it and what you've done and how you're advancing the field in that area.
Yeah, sure. The desmoplastic small round cell tumor, and I only say it twice, and then heretofore to be known as DSRCT. Desmoplastic small round cell tumor is a rare type of sarcoma, very rare, rarer than even what we think is rare in our sarcoma world. And so there might be maybe 50 to 100 cases in the US every year, very rare tumor. And the interesting and bad thing about it is that we know how to identify it by its genetic rearrangements, but we don't know where it comes from. Like, you know, for an example, for the parents, you know, colon cancer comes from the colon, breast cancer comes from the breast. We have no idea where DSRCT starts. All we know is when we see it, it never shows up as one lump. It always shows up as dozens to hundreds of little tumors in the abdominal cavity, sometimes very big tumors in the abdominal cavity. And because it shows up as so many tumors at once, we don't know where that one tumor actually started. So it presents problems in that way because when you talk about, let's say, 100 tumors, and when I've done these surgeries, they last 10 to 20 hours, and we've taken out up to 2,200 tumors over 22 hours. So they can be quite extensive. And so you say to yourself, like, how does a tumor like this get that way? Mm-hmm. And why is it that it is that way? And that's what started me questioning things and wanting to do things in the laboratory to understand it. So the other interesting thing about it is it happens in mostly boys and men. So 90% of the patients are male. So that gave me some clue as to maybe it was a hormone-driven tumor because it happens in mostly males. And if it was male hormone-driven. But the other clue I had was I've operated on probably over 100 DSRCT patients, which doesn't sound like very many, but is a lot for DSRCT.
Yes.
Yes. And when I'm dissecting the tumor inside of a male, and the tumor usually sits behind the bladder and in front of the rectum, the biggest tumor. And there's a whole lot of smaller 1-2 millimeter tumors in the rest of the whole abdominal cavity, but this one sits there. And so I am frequently, if not probably 90 to 100% of the time in the boy, cutting the tumor off of an organ called the seminal vesicle, which connects to the prostate glands, part of the male genitalia system. And I asked myself, why am I always cutting it off of this structure? It's not a prostate cancer. It doesn't come from the prostate. So why am I always cutting it off of this area? And as I looked more into the cells itself in the laboratory, you find that the cells have androgen receptors on the cell surface, and androgen is a hormone that drives sperm production in boys and men. And to make a long story short, we showed in one of our manuscripts that this hormone sensitivity of the DSRCT can actually be controlled by treating it with or without testosterone in the laboratory and getting it to grow or not grow. So that's important information, because then we can sort of look more towards the genetic pathways that are associated with male hormones as opposed to sarcomas. And actually, when you look at the DNA and RNA in the cells, you find that the DSRCT cells look more like prostate cancer cells than they do sarcoma cells. They behave that way when you look at them genetically using RNA. So that was very interesting to see. And so from that, this whole process I'm describing took about 5 years to figure out. We decided to take the human DSRCT cells, for which there's only one cell line in the whole world available, so it's very difficult to study. And we injected it around the seminal vesicles, the same place, in a immunocompromised mouse. And only when we injected it in that particular location did the mice get the exact same thing that the humans get, with multiple tumor implants in the abdomen, some lymph node metastases in the neck. As you know, they can get lymph node metastases in the neck and in the chest. Looked identical to what we see in humans. But that's only when we injected it around the male developing system called the seminal vesicles. If you injected it around the kidneys and the abdomen, around the liver, in the belly, in the arm, in the leg, it won't grow. It just won't grow. So that was very interesting. And it's exciting for us now because it allows us to study that disease very specifically. And the other thing we learned, two more things I want to mention that we learned about this disease. One is that surgically, you have to remove everything that you can see with your eyes. You can't even leave a 1 millimeter implant in there because it'll just take off like wildfire. And the reason is the tumor sits on this tissue called peritoneum. And if you think of peritoneum like saran wrap, it's just a thin layer that you can't even really see, and you can see right through it. It's clear. And it covers all the organs in the abdomen, the liver, the spleen, the intestine, the stomach, the colon. And God put it there so that the tissue doesn't stick together. It secretes a little tiny bit of fluid so that your intestines don't stick to your liver, etc. And so these DSRCT cells sits on top of this peritoneum, and it doesn't usually invade through it into the organ. So my job as a surgeon is to peel that off of the organ and leave the organ intact. And so it comes out in like sheets of saran wrap with little dots in it that are the tumors. So removing that is really critical to keeping the tumor from coming back. And then we've also learned, and that data actually was done a while ago at Memorial Sloan Kettering, but then what we found out at Anderson was that at MD Anderson Cancer Center was that the addition of the hot chemotherapy prolonged their survival even more. So you have to get out all the disease you can see, and then an additional layer of adding the heat plus the chemotherapy, which kills the microscopic cells sort of on contact, if you will, in the abdomen. And the reason that's different from other tumors is that when you guys give chemotherapy, obviously it goes through the veins and through the arteries and to the tumors. Well, these tumors on the peritoneum, they don't have any blood vessels. So you can't get the chemotherapy there to kill them because there's no, the blood vessels are so tiny that you can't get the chemotherapy to penetrate. And so you have to use surgery to remove them, because otherwise they'll just grow on this little thin clear sheet where there really isn't any blood vessels getting to. So that's what's important about that disease. The last thing I'll say about that is the staging of that disease, I'm also working on changing. So as I mentioned before, every patient presents with dozens to hundreds of tumors. So as most people know, cancer in general goes from stage 1 to stage 4 in general. So when you're talking about abdominal tumors and sarcomas, if you have hundreds of tumors, you're automatically going to be a stage 4. And so, because it's metastatic. And so how do you compare a patient that has hundreds of tumors but no tumor in the liver to the patient with hundreds of tumors and tumor in the liver? So I have a new staging system I propose, which is pretty simple and straightforward, that just says either you have disease that is confined to the abdominal cavity but not in the liver or the lymph nodes, or not. So stage 1, for example, would be, stage 1 is very, very rare, but every once in a while we find a patient that just has tumor in the omentum, and it's several tumors in the omentum, and that would be a stage 1 because that's just sort of one location. Stage 2 patients would have hundreds of tumors everywhere on top of every organ. Stage 3 would include patients with liver metastasis, and stage 4 would be everybody else with metastasis in the lymph nodes and the lung, etc. So that helps us as providers think about patients and talk about them on the same level. Because if we're both saying stage 4, but your patient has liver and lung metastasis and mine doesn't, they're not going to behave the same for obvious reasons. So I'm hoping that we can get that new staging system sort of accepted so that clinicians and providers can talk to each other in a way that allows us to understand what type of patient we're talking about.
Yeah, that's great. DSRCT is so rare, and trying to learn anything about it is extraordinarily hard. And something that you said struck me, which kind of ties back to our conversation with Dr. Corey Painter, Lisa, where you were saying, I observed this. I noticed that this was always occurring around the seminal vesicles. We had a conversation with Dr. Corey Painter. I don't know if you know her, who is a survivor of angiosarcoma and a researcher and works at the Broad now, was talking about an observation in angiosarcoma patients and how noticing these patterns of the way patients present or what patients report, in her case, can lead to interesting scientific discoveries that take you down another pathway for research. So it's kind of a nice tie-in to how these very rare diseases takes somebody who's very observant like yourself, who's doing a lot of these surgeries, or it takes collaboration to bring data sets together, because you can't do it at one institution normally because they're so rare. And the other thing that was just a comment. The other thing I wanted to ask, because I get asked this question probably all the time, and I think I know the answer, but I'm not a surgeon, so I'm going to ask you. And I don't know if people ask you this when they see you, but when I talk about surgery with my patients, and you were talking about looking at and removing all these tiny little tumors, a lot of time my patients say, how does the surgeon know what a tumor looks like? And I always say, they just know. They're trained to know what that looks like.
Exactly.
Is that the answer?
Right. No, that's a good answer. You did great. Yeah, it looks different from the normal tissue. I think you have to know, like when people say, how do you know that's Aunt Betty? Well, because I've seen Aunt Betty 50 times, that's Aunt Betty. You can't really describe Aunt Betty, but I know that that's Aunt Betty. So it's like that. It's almost like facial recognition. You can see the difference in the normal tissue. You know what's normal, and if something doesn't look normal, that it might be tumor. Sometimes it's something like scar or something like that. And if we're unclear, if we're in a space and we're not sure if what we're looking at is tumor, that's when we send it to the pathologist while we're in the operating room. And we say, hey, we don't know what this looks odd to us, doesn't look normal, but can you tell me if it's tumor? And so if we have a question about whether it's tumor, if it's not completely obvious to us, they can do what we call a frozen section, which is a quick look at the tissue and tell us, is this a tumor or is it something else? So that can be
Yeah,
sometimes.
that's great. We're actually having a sarcoma pathologist on in September, right, Lisa? So
Yep.
I think it's one of the unsung heroes in the public eye for sarcomas is
Yes.
our pathologist, because I can't do anything without them,
Can't do
and
anything
neither
without
can you, quite honestly.
Right.
Like, we need to know what it is. So we're excited to have her on. So
yeah,
we'll talk more about their role in sarcoma and how critical they are. So that was
yeah, they're so critical. I tell patients all the time, the first thing you want to do is make sure the diagnosis is correct, or else we can't treat properly.
absolutely, absolutely. Go
Yeah.
ahead, Lisa.
Well, just I just it's just so amazing all the what you found out from the bench to the bedside, all these separate little pieces to help advance. And it's like you would just be amazing if you were a great pediatric oncology surgeon, which you are. But the fact that you take the time to do the research too and fit that all in, um, I know the whole sarcoma world is grateful. And that's really cool what you found out with the seminal vesicles. And I, and you said, well, that took 5 years, but I know, Wendy was just talking about last week too, because Wendy's done a lot of bench research that, everything, it takes time to do this research. And so 5 years is actually fast to have discovered all those things. So
Absolutely.
That's right.
Especially in this
yeah.
disease, for sure.
Yeah. And then, that was one of the things when I came to MD Anderson that I was amazed with the whole surgery itself with the hot chemo. And can you explain a little bit more about how you all do that and how I don't know if the origin came up. Do they do that in ovarian cancer sometimes too? If that's where, because you're the one who really pioneered this. So how did you get the thought, well, you know what, this could maybe work here and I'm going to try it out. So how did that all process happen?
Yeah, so well, I started off, I did part of my training at St. Jude, and most people
Mm-hmm.
I'll probably know St. Jude very well. So I did 2 years training in pediatric surgical oncology at St. Jude's Children's Research Hospital, and that's where I met the first patient with the desmoplastic small round cell tumor. And it was an unfortunate child because we weren't able to do surgery on them, and then they ended up passing away shortly afterwards. And I remember he was around 12 years old. And I, as a fellow, had to be the one to go out and tell the parents that we couldn't do anything surgically. And it's an awful, awful, terrible feeling to have to do that. As a surgeon, we go into surgery because we like to fix things. And the last thing you want to do is come out and tell a parent that you couldn't fix it. So that got me interested. That was in 1998. And the tumor had just been discovered like 9 years prior to that. So I went to the microfiche in the library. I know those two words are foreign to most 20-year-olds, but there was a place called a library that had books. And if the books were too old, they put them on little pieces of film that you had to read. Anyway, so I went looking into the microfiche and found like one or two articles, and I realized that no one really knew anything about this disease. So I became fascinated with the disease at that point. And everything I read said it was incurable and that the survival rate was only 10 to 15%. And there
Yeah.
really wasn't any long-term survivors after 5 years. And it was really dismal. And then I went to MD Anderson to do a melanoma and sarcoma fellowship. And there they were doing a phase 1 trial on HIPEC in adults, not in DSRCT, but in a different tumor type. And I was part of that clinical trial as the fellow helping
Mm-hmm.
surgery. And that's how I learned the technique. And I started to ask myself after I saw several of these patients, maybe we can try this in DSRCT. And so I started to ask my adult colleagues in surgery, and they said, oh, yeah, no, you can't do that. In kids, it's too toxic. You're pouring hot chemo into the abdomen. And then I asked my pediatric colleagues, and they said, oh, yeah, you can't. That's crazy. I don't know what you're talking about, but it sounds weird. And no, you can't do that. So I didn't really have any support on either side, but the concept is that you go in and take out these hundreds of tumor cells, and you've got these microscopic cells floating around, and you want to keep the tumor from coming back. So stage 1, get the tumor out. First thing you do, get the tumor out. Second thing you do, keep the tumor from coming back. That's why we need the whole team of chemo, radiation, and surgery. So part of what HIPEC does, and the acronym stands for hyperthermic intraperitoneal chemotherapy. Part of what HIPEC does is it takes the heat, and this is at 41, 42 degrees Celsius, about 106, 7 degrees for Fahrenheit, and it adds the chemo to the heat, and it synergizes so that the heat plus the chemo kills the microscopic tumor cells much better than either one could do by itself. So we imagine the belly's open. I've done the surgery, taken out all the tumors. Then we temporarily close the skin, and then we have an inflow and outflow catheter that goes into the belly, fills it up with a few liters of hot chemo, goes out the other tube into a pump that warms it and back around in a circle. And so that happens for 60 to 90 minutes. And we stand there and sort of swish the chemo around in the abdominal cavity, make sure it gets to all the nooks and crannies. And that we have shown will kill these microscopic tumor cells and either delay the progression forever, so they never get the tumor, or it won't come back in the abdomen. And unfortunately, it might come back somewhere else. But it totally sterilizes, if you will, the abdominal cavity of the tumor.
So do you swish with your hands?
No.
I was like, wait.
No. No, there's some surgeons who do in HIPEC, actually. In HIPEC, sometimes they take their hand, they just put it inside, and they literally stir for an hour.
Wow.
Do that. That's called an open technique. The closed technique, look at
it's a workout.
Wendy's face. The closed technique is you close the skin, so the skin's closed over these two tubes that go in and out that are watertight, so nothing leaks. And then you sort of gently touch the abdominal cavity and move it like this, so it, it distributes fairly evenly. At that point, I leave the room. The resident does that. I take a break.
That's right. That's interesting, because that was one of the other questions I was going to ask you, because you did mention that some of these surgeries, whether it's HIPEC or a different, or even just a difficult tumor to remove, could take hours. So how do you mentally prepare, and then how do you do that for hours?
Oh, wow. People are going to think I'm crazy. That's why I'm laughing. But
no.
So if you think about it as training for a marathon, right?
Yes.
So there's certain things that you do. You have to do it the same way every time. It's going to be 26 miles or whatever it is. Mm-hmm. So this, I have to. I don't do it as often, but when I first started doing it, I was doing 1 a week and sometimes 2 a week. And so your body has to get into this rhythm of not thinking about going to the bathroom, not, remembering that you have any, back pain or your feet hurt or whatever from standing that long. So a few things. One is one of the scrub nurses at Anderson started this for me, and I still do it. As she gives me a pad that's about this thick, it's foam, and I stand on the pad for the whole time. So that saves your back, so I never get back pain. Then I have a very strict regimen of what I eat, drink the morning of the surgery. So the morning of the HIPEC, I have a bottle of water on the way to work. Then I have oatmeal, 2 scoops of brown sugar, and 10 raisins. Not
I love
one
it.
more, not one less, because if
it
you
could
have
throw it off.
Carbs, then at about 3 hours into the surgery, you're like, so you can't do that. So it has to be very specific. Can't have any, a lot of protein, because if you have too much protein, then you won't have the energy to get through the case. And then a little half cup of water with the oatmeal. So then I go to the bathroom right before the surgery, and then I don't have to feel like I have to go to the bathroom for 10, 12 hours.
It's amazing.
And so that keeps me from being hungry, keeps me from being thirsty, and keeps me from having to feel like I have to go to the bathroom. And so after about 10 hours, I take a break. But 10 to 12 hours in, I'll take a break. And I take an hour break while they're doing the shaking for the HIPEC, and then I go back in and finish the surgery.
So do you eat anything on your break?
Yes, on my break after 10
Another
hours.
10 raisins or almonds?
Then I have to have something warm. I know it sounds weird, but you're in this cold operating room.
Yeah.
So I usually have a cup of, herbal tea and something with something. Usually I treat myself with some bad carbs like French fries.
That sounds amazing. Yes.
You need like a treat when you come out. So usually it's just, the cafeteria is usually closed, so it's nothing hot. It's usually a cold sandwich and French fries or salad and French fries.
Mhm.
That's amazing. I love it. It's
Yeah.
Lisa, you run marathons. I used to in a former
Well,
life.
no, I still not run a full, just a bunch of halves. Because the full one, right? You have to have the regimen down for eating, which I actually, I did sign up for one, but then, COVID ruined it for me. So,
Yeah. Thanks,
but what,
2020.
2021 is my year.
There you go. There you
But
go.
it is true that is so much like a marathon when you think about like the regimen and the training, and that's how you're successful in a marathon anyway. Because you can finish a marathon and be crawling at the end, or you can finish it in good shape, so you could do another one 2 days later, like you do with
Exactly.
the
Yeah.
surgery.
Exactly.
Exactly.
Because you're
Yeah,
doing
no,
ultras by that
yeah,
point.
no, and then
Seriously.
and I do the sequence of what I operate on first in the abdomen is the same every time. So I do,
Hmm.
this first, this second, this third, this fourth. So it's also very regimented.
That's great. That's so cool. Is there so your research in HIPEC has been spanning several years now, and I used to know your bio when I had my conference and I was looking at it. And now most people are doing HIPEC for DSRCT, but there's still people that are investigating HIPEC for other tumor types, and there's ongoing studies, right? Can you tell us a little bit about that?
Yeah, the phase 2 study that showed that that HIPEC was really effective in DSRCT with the 80% 3-year survival, also showed that it wasn't very effective for rhabdo because there were rhabdo patients in that study also. And we use cisplatin as the drug, and as you guys know, that's not a common drug we use. We don't use it for rhabdo for systemic therapy. And so there's only a certain number of drugs that have been tested and are known to be synergistic with heat. So for sarcoma type drugs, there's only 3: etoposide, doxorubicin, and cisplatin. And so I decided to start using doxorubicin instead, or in addition to the cisplatin in the HIPECs. First, I started doing it instead of the cisplatin, and then I had a patient had a recurrence and said, maybe we should use a combination. So now I use cisplatin and doxorubicin in the HIPEC solution for the rhabdomyosarcomas. And we don't have enough patients yet to have enough long-term data, but I'm hoping that's going to be more effective. And if we get a better drug for rhabdo, I'm happy to use that too. But the other drugs that we use in rhabdomyosarcoma are not synergistic with heat.
There was a small study out of Europe using the combination. Is that correct?
Yeah, from Germany.
Yeah.
My colleagues there. Well, what happened is the Italians were using it in adult sarcomas, uterine sarcoma in particular. They were using the doxorubicin and the cisplatin together for uterine sarcoma, and so I adapted that as a protocol for the rhabdomyosarcomas. And the German European group that's also doing HIPEC in rhabdos and DSRCTs uses that same regimen.
Cool. We're almost to the end of our time, and I know that Dr. Hayes-Jordan and Dr. Kopp have another call coming up. One question I've been dying to ask you, because I think this is so helpful to parents who may feel a little bit lost at the beginning or even kind of midway through their journey, is what would you say are the 3 most important questions for a parent or a patient to ask their surgeon in that initial consultation?
That's a good question. Okay, what are the 3 most important questions the patient should ask the surgeon? 1, are you sure you have the diagnosis correct? Because the pathology is so important in sarcomas, more than any other tumor, I think, way more important than any other tumor. Do you think you can get a negative margin and leave my child intact? And probably the 3rd one is, how much experience do you have operating on sarcomas? Sarcomas are rare, and I think I might be up to 1,000 cases if I took all of them for the last 20 years that I've operated on. But it's not like adult tumors where if I went to see a colon cancer surgeon, they would tell me they've done 10,000 or whatnot. So, even though the parents should ask that question, doing 50 is a lot for sarcomas. And knowing that they have that experience. I always, when I talk to parents, tell them that I'm on the COG sarcoma committee, and I've been doing that since the inception of the COG. And having a surgeon that's involved with the COG is also really helpful. So having the sarcoma experience and being involved with the Children's Oncology Group is also means that they have a commitment to understanding sarcomas. So I
Yeah,
think that,
that's a good context to base it on, because I think it is scary when you hear, I've done, 52 surgeries, and you're thinking, oh, that's not very much, but
yeah,
it's a great depth of experience. And
yes,
I think it's empowering to hear a surgeon say, it's okay to ask my surgeons these questions. Like, it's okay to ask you, do you have adequate experience in this field?
mm-hmm.
I think medicine is changing for the better. And I think, our patients are becoming better advocates for themselves and for their children. And some of those questions that are kind of uncomfortable sometimes to ask about your experience with a certain tumor type, seeking second opinions, surgical opinions, they can feel uncomfortable for parents. But I kind of just want to put a plug that I never mind. I know Dr. Kopp never minds if people ask for second opinions. I think that's a
Yes,
smart thing to do if you feel like you need to do that, and it doesn't offend a good physician, whether it be a surgeon or an oncologist. That we should all be open to helping our patients achieve the level of comfort that they need to proceed forward with their therapeutic plan. So I'm
right,
glad you said
right.
that.
Yeah, I think a
Yeah.
second opinion is really important because I have patients that come to me for a second opinion or I send them for a second opinion. And, some parents have said, well, why is it that you say the tumor is resectable and Dr. Y says the tumor is not resectable? I said, because Dr. Y hasn't done 50 of these cases. And so it's hard for him or her to know whether it's resectable or not.
Mm-hmm.
But that's why that experience is so important. Sometimes parents are confused and they think, oh, a surgeon is a surgeon. You should just be able to take it out. It's like, well, no, you have to actually have some experience, especially with something so rare as sarcoma.
Yeah.
Yeah, like you're both saying, I think it's important that they feel empowered and they shouldn't let other people talk them out of getting a second opinion. If family members are like, oh no, you just got to get it taken out right away. Because like we talked about before too, you have a little bit of leeway with
Yes,
the sarcomas where you have a little bit of time too. So you should get that second opinion and feel comfortable with the surgeon who's doing it.
exactly. Yeah, you do have a little bit of time, and the surgery can be done incorrectly, and it can really affect the survival of the patient if they don't take out 100% of the tumor and they say, oh, yeah, I can get it out. And then they go in there and then your child wakes up and they tell you, oh, I'm sorry, I can only get half of it out. That's sort of a nightmare because
Mm-hmm.
we know that it's sort of a wives' tale, but sort of not, that if you leave tumor behind and you don't have chemotherapy to back you up, meaning they haven't gotten it before surgery, then the tumor will just grow like wildfire. So it's like pouring gasoline on a fire because the body is trying to heal the wound of the surgery, and the same proteins that the body calls to heal wounds cause tumors to grow. And so it can be worse to operate on and not do the right surgery because now you've made the tumor grow as opposed to just waiting to get to a surgeon who has some experience.
Yeah. I think at the very beginning, I get that question and concern a lot about, people will say, well, you can't cut on a tumor because it will make it grow. And I think what, you're saying is doing these big surgeries and leaving some behind definitely brings in these wound healing things. But we don't see the same thing if we do a small biopsy. Because a lot of people are very afraid of that initial biopsy, but a small little biopsy is not the
Right.
same situation as you're talking about,
Right.
right?
That's just a needle and it's not a big incision that you have to
Yeah.
heal. It's a small puncture. Correct.
Yeah. So fascinating. We could talk forever, but we're at
I
4 minutes,
know.
Lisa.
Yes. Yeah. So, yes. So we'll let you go, but we want to just thank you so much
Oh, thank you for having me.
for
Thank you for
talking with us. Yes.
Yeah,
And for
this
all
has
that you
been
do, because
amazing.
we're big fans. Yay.
I know. Big fangirls. Yeah, this is so great. Thank you for taking an hour out of your day. I know that's time
Yes.
is the biggest commodity for all of us. So we really appreciate your
Yes.
graciousness and speaking with
no
us. And
problem.
I think this will be very helpful to many families going forward. And it's great because it can be on demand for them, as they need
Yes.
it, as they go through their journeys. So thank you so much.
Thank
Yes,
you.
you're so welcome. It's my pleasure. And I'm just going to keep following you guys. I'm going to add another follower.
Yay! Please rate us and review us on Apple Podcasts.
There you go.
We'll be up to 10 after yours.
I
All
know.
right.
Thank
Thanks,
you.
Sarcoma sisters. See you later.
Thank you. Bye.